Welcome to the conference session titled High Risk MDS Non-Transplant Therapies. Thank you for joining us. My name is Nyari Sireu, Patient and Professional Program Coordinator, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit your questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all the questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, that you submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Prajwal Dhakal. Dr. Dhakal joined the Division of Hematology Oncology and Blood and Bone Marrow Transplantation as a clinical assistant professor in 2021 at the University of Iowa Healthcare after having completed his Hematology Oncology Fellowship at the University of Nebraska Medical Center in Omaha. He received his MBBS from Tribhuvan University in Nepal, followed by an internal medicine residency at Michigan State University in East Lansing. Dr. Dhakal's clinical research interests include acute myeloid leukemia and myelodysplastic syndrome, with special focus on new and targeted therapies for relapsed and refractory disease. With that said, please welcome Dr. Dhakal.
Thank you for this opportunity to be here and present this, and welcome to all the online participants. Okay, so I will be talking about treatment of high-risk MDS. Okay, so a lot of things will overlap between me and Dr. Bhatt's presentation, but hopefully that's more helpful. So we'll start with what is high-risk MDS. We hear a lot about low-risk MDS and how to go forward. So in terms of high-risk MDS, the goals are slightly different. So this is MDS that needs treatment as soon as possible, and that's to prevent complications, delay progression to acute myeloid leukemia, AML, in a short period of time, and prolong life. So what makes this high-risk MDS is there are lots of multiple factors which define high risk. So it would be bone marrow blasts. When I mean blasts here, they are cancer cells that we see in the bone marrow. Cytogenetics, meaning a lot of changes in the chromosomes that we see in the bone marrow again. Blood counts, there are different kind of blood cells, red blood cells, which we count in terms of hemoglobin, platelets, and white blood cells. Usually with white blood cells in MDS, we focus more on neutrophils. So these neutrophils are infection-fighting cells, and anytime they are low, we're worried about infection. And there are other genetic abnormalities in the genes and chromosomes, which are equally important as well. And we stage this MDS with a different scoring system because it's not a solid cancer, so there are different ways to look at them and figure out the risk part. So this is IPSS, is what we call International Prognostic Scoring System for the MDS, and it includes a lot of factors there. Again, bone marrow blast, meaning cancer cells in the bone marrow, cytogenetics, chromosomal abnormalities, low blood counts, again, hemoglobin, neutrophil, platelets, and genetic abnormalities and mutation. So initially, when they made this scoring system, just these 3 points were there. So blasts, cytogenetics, and low blood counts. Just a pretty easy way to look at the disease and figure out the high risk. Now, it's been slightly modified, and we have added few other things. Now comes bone marrow blast. We again look at chromosomal abnormalities, low blood counts, and this time we're being more specific in terms of looking at hemoglobin, neutrophils, and platelets as well. And this is, at this time, commonly used scoring system, and a lot of clinical trials and studies look at this scoring system, and we're still using it pretty commonly. So now, recently, we have started including new molecular abnormalities like changes in the genes, which we call mutation, and this is, we're moving towards what we call IPSS-M or IPSS molecular scoring system. And in this scoring system, we include TP53, which is actually a very common mutation in lots of cancers, not so common in MDS, but with very worse prognosis. And there are other mutations like AXSL1, RUNX1, FLT3, MLL, which are worse. There are a lot of other worse mutations as well, but one of the good ones is SF3B1. So summary, I think what we should know is there are a lot of mutation. Basically, a lot of them would be on the worse prognosis side. And we're still working on figuring out what they are. So just to give you some idea of how things change from very low to very high. So when you look at the very low part, what we see is on the very low risk, median overall survival is 8.8 years. So half of the people actually live till, let's say, 9 years. And the chances of progressing to AML for one-fourth of the people is almost 15 years. So that's pretty good, and that's very impressive. Coming down to very high risk, overall survival is just 0.8 years, meaning less than 1 year. Again, there's very high chance of transformation to AML, again, less than 1 year there as well. So lots of different prognosis there, which kind of makes differences in how we treat them. And when you look at the red box there, high and very high are more of what we, more in the higher risk, obviously, but intermediate, we kind of tend to get them up and down based on a lot of factors, but just to give you some idea of how bad or how good it can be. So now coming to this new scoring system. In this part, we're looking with 5 different risk groups. Now in this molecular scoring system, now as we know more about the genes, the risk groups are divided into very low, low, moderate, high, high, and very high. Again, looking at very low, which half the people survive almost 11 years, compared to very high, it's 1 year. And on the right side, where we look at transformation to AML, acute myeloid leukemia, by 4 years, almost half of the people go to leukemia in very high risk compared to less than 3% in the very low risk. Again, a lot of difference there, and that's why we kind of tend to differentiate MDS into low risk and high risk group. Now coming to the treatment goals. In the low risk part, we're focusing more on supportive care, trying to kind of focus on low blood counts, anemia, low platelets, and trying to take care of all the comorbidities as well. But here we're more focused on treatment of MDS in addition to other goals. So here our goals are increase the number of healthy blood cells in bone marrow, decrease blood and platelet transfusion, decrease the risk for other complications like infection, bleeding, and decrease the risk of progression to AML. So when we say healthy blood cells in the bone marrow, again, there would be a lot of cancer cells with high-risk disease. So we're trying to kind of increase the rate of these healthy blood cells being made. Again, when hemoglobin is low and platelets are low, we need to give blood and platelets to the patients. That's when we're trying to get those transfusion levels low by treating the MDS itself and not just giving the transfusion. Same thing for the infection and bleeding. We're trying to get the neutrophils and white blood cell up and kind of decreasing the risk of infection. Similar with bleeding, when we're trying to get the platelets number up to make sure that there is less chance of bleeding. And decrease the risk of progression to AML. As we said earlier, there's very high risk of getting high-risk MDS to AML. So with these treatment goals, again, ultimately it comes to whether we want to cure MDS or prolong life, make people live as long as possible, not necessarily cure the disease or improve quality of life. Mostly with quality of life, again, transfusion, decrease coming to the hospital and clinics to get those all of transfusions and other meds as well. So how do we treat the person? How do we choose the right treatment is one of the most important questions in this MDS part, high-risk MDS. So the basically first thing comes to what the person wants, what's their goal is, the long-term goal and short-term goal, and we'll talk more in detail about this. And second thing is medical fitness. And again, when we say fitness, what does that mean? Does it mean like age? Does it mean like how active the person is? What is it? And again, we'll discuss more. And disease characteristics in terms of how bad or how good the MDS itself is. So talking about patient preferences and goals, one of the most important things would be how much effective they want the cancer treatment to be. Is it curing the treatment, which may give a slightly different treatment plan? Is it prolonging life, meaning is it they're not necessarily worried too much about curing the disease, but would like to increase their life expectancy as long as possible? And is it more of symptom relief? Is it fatigue and weakness that we want to treat with increasing the blood counts, bleeding, increasing the platelets, again, preventing infection and those kind of things? Next would be toxicity. Again, what's the short-term and long-term side effects that we're trying to avoid? Is it more of long-term cognitive ability, long-term pain, long-term neuropathy, those kind of things, versus acute neuropathy, which could go away after treatment, acute pain, acute bleeding, transfusion, and those type of things, which is okay for short-term but would not want in the long-term. So next would be treatment characteristics, and that encompasses a lot of things, but as we said, hospital visits, admission. So sometimes people may need to be admitted to the hospital just for the treatment, let's say for some kind of intravenous treatment. So would they really want that, or would it be better for them to just get the pills and just stay home and do less labs as possible? And financial burden, as we know, the treatment these days are getting really, really expensive. So would they what's their goal in terms of the finances. A lot of times they may be requiring to pay a lot of high co-pays, more finances for the new drugs. Would they really want that, or just go with something that's pretty not so expensive and been there for a long time and pretty straightforward? And another would be like route of administration. How do you get the drug? Would it be just pills? Because a lot of drugs in the MDS from years has been more of intravenous and shots. But newly there have been some pills. Would they rather get the pills and not get the shots? Because for getting the shots, you have to again come to the clinic, and for people who live far away, it's a really hard thing. So those would be a lot of preferences and goals from the patients, and we have to always look at these things before making any final treatment plans. And another is disease characteristics, how what the disease looks like, how bad or good the disease is. So in a lot of, when we, as we said, when we put the disease in high risk, we look at changes in chromosome, which we call cytogenetics, which we've been looking at for a long time, for years. So that's one of the factors which makes the MDS bad in some ways. I mean, in sometimes good, or also mutations in different genes. And I just listed few here. TP53, that's again a really bad mutation. There are others that they have looked at, like EZH2, ETV6, RUNXN1, and AXSL1, which actually are supposed to be worse kind of mutation as well. And SF3B1, that's more on the better side. And other genes like IDH1, IDH2, we've not necessarily found good relation between prognosis between these genes, but they actually have pretty good targeted therapy, so that's something that we usually look at as well. So a lot of things to think about in the disease. We talked about patients, goals, and now comes the medical fitness. So that's where we're trying to be very aggressive versus less aggressive, and kind of meet the goals and preferences there. So first thing would be performance status, meaning how active or inactive the person is. Is he or she able to do regular activities around the house, or does the person need help even with eating or getting shower, those kind of things. And comorbidities, again, it's really bad heart disease, lung disease, liver disease, those kind of things we should obviously factor into. And these days we're trying to do what we call geriatric evaluation. It's more on the older patient age group, again, which is very common in MDS. So we're trying to include cognitive ability, all performance status, comorbidities in the geriatric evaluation together to figure out the fitness itself. And age is usually considered one of the factors in medical fitness, but that should not be the only factor, because even if someone is, let's say, 70-year-old, they may be pretty active compared to someone with 60-year-old who have a lot of comorbidities. So it's a more of arbitrary risk factors in terms of age, but definitely something that we should think about in addition to other factors. So after looking at all these strategies in terms of how to figure out the best treatment, we'll talk about the treatment part now. So there are a lot of ways to treat high-risk MDS. So I've listed here the most common is what we call hypomethylating agents, HMA, and the two most common are azacitidine and decitabine. These drugs are mostly used, and they've been here for decades and have shown really good effect on the MDS. And the next one, decitabine cidazuridine. This is a relatively new drug, recently approved for MDS. It's a pill, which actually is very attractive to a lot of people these days. And the third is intensive chemotherapy. Again, this as the name suggests, intensive. So it would be very aggressive, high dose chemotherapy agents, more like what we use in AML. Fourth would be bone marrow transplant, which is actually the only cure for the MDS. And again, it's very aggressive, actually even more aggressive than intensive chemotherapy. And we'll talk more about bone marrow transplant and supportive care. And for the supportive care part, everybody with MDS needs supportive care, so should be incorporated in any kind of strategy. So we'll talk about azacitidine. So how we can give azacitidine is it can be given intravenous, IV, or subcutaneous, meaning a pretty easy shot that you can give in your belly or thighs, and which is pretty easy in that regard. And it's we usually give it in outpatient setting, meaning that we give it in clinic, and it's like 5 to 7 days IV or shots, and it's given every 4 weeks. And so every 4 weeks, meaning 4 weeks is what we consider one cycle. So people have to come to the clinic, get the drug for 5 or 6 days straight daily, and then they just look at labs and get the supportive care, and the cycle repeats every 4 weeks. So how did this drug came into the treatment part of MDS? So this is the data that we have. It's a phase 1 clinical trial. This is the base data that shows that azacitidine is very effective compared to conventional care. And when I say conventional care, they talk about other kind of treatment strategies like just supportive care, intensive chemotherapy, or another drug called low-dose cytarabine. So compared to those drugs, azacitidine, so that half of the people lived for almost 25 months compared to just 15 months for other disease. So very significant, very effective, and that's what we cite when we use azacitidine. And so there have been a lot of studies where people have tried to add drugs to azacitidine to see if that would help more, but the results have not been that impressive. But the best response, what we have seen with azacitidine, is just continue with the cycles every 4 weeks without any delay, and for at least 6 cycles. And with the combination, actually, there was a lot of delay in between, and most likely that's what did not help with the overall survival. And that's what we try to aim for, at least 6 cycles, and continue that every 4 weeks. And the other drug decitabine, very similar to azacitidine. I usually call azacitidine and decitabine are kind of cousins. So decitabine is intravenous, so it does not have a shot, but just needs IV. And we give decitabine. There are lots of ways to give it, but it's usually 3 to 5 days every 4 weeks. 4 week here again is one cycle. And the best response, again, with decitabine is just like we did with azacitidine, continuous cycle without any delay in between. So similar to azacitidine, we don't have a good data from phase 3 randomized trial though. So when they compared decitabine with just supportive care, overall survival was only 10 months versus 8.5 months. But this result should be looked at it with a little grain of salt, because when they did this study with decitabine, the study population was slightly different compared to the one in azacitidine part. Just by looking at the median overall survival with decitabine, it was 10 months compared to the azacitidine where it was 25 months. And the patients who just got supportive care, they lived for around 15 months compared to 8.5 months here. So slightly different population, but even this does not show any significant result. We still consider decitabine to be a pretty good disease, and there have been a lot of database studies and retrospective studies which showed that there's no difference in azacitidine versus decitabine. So in real clinical practice, we just use them interchangeably. Either one is fine, and both are pretty effective. And the new drug, so this is decitabine sirazuridine. What they did was they added added sirazuridine to the decitabine. So it's kind of a fixed dose combination, and the thought process behind adding this sirazuridine was decitabine, when given through mouth, it gets inactivated pretty fast in the gut, stomach. So what they did was this new drug, sirazuridine, it acts against the enzymes in the gut and increases the absorption of decitabine. So basically, patients who got this oral drug had pretty good amount of decitabine in the blood, very comparable to what we did with IV drug. So there's studies going on with this drug as well, but few early phase trials basically showed that the results were pretty comparable between IV and oral drug, and that's why we've been using this pill as well. Again, relatively new drug, not a lot of data, but very impressive. And we give it every 5 days, 5 days every 4 weeks. And the good thing with this is patients don't necessarily have to come to the hospital daily for 5 or 7 days. So you can be home, take the pills, and check your labs as needed. So this is the long list, but most of them are very mild. So we're talking about the side effects from azacitidine, decitabine, and the pill as well. Very mild side effects, but a lot of side effects can happen. And most of them, people don't usually realize that it's from the drug. Low blood counts. Again, with any kind of chemotherapy, we get low blood counts. The thing with azacitidine and decitabine is the blood counts do not go very low and does not necessarily last long. So even if you have, let's say, low hemoglobin or platelets to start with, even these drugs, even if they get those counts down, they come up pretty fast. And then soon after they start, soon after you get the response from these drugs, then the blood counts come up pretty fast and they don't go as low. Nausea, vomiting, they are actually most common side effects, nausea. We have very good drugs for nausea these days, so should not be a problem in that regard, and people tolerate this pretty well. Diarrhea, some people have diarrhea, some people have constipation, and it's very kind of random who gets what, but we can take care of those very easily. Fatigue, loss of appetite, They usually go together with the low blood counts, especially at the early part of treatment. But as you get more of response from the chemotherapy, those side effects usually go away or becomes very manageable as well. Same thing with mouth sores. Mouth sores are very common with intensive chemotherapy. You don't get a lot of mouth sores here, but again, very mild. Skin rash, they can be kind of very, again, mild. Sometimes people don't even realize that it's there, but you tend to get it. It can be itchy, but no other concerns in terms of bleeding, ulcer, those kind of things usually. Fever and neutropenic fever. So you can just get fever without any kind of infection there. Usually goes away. Neutropenic fever is something we'll worry a little more about. And when we say neutropenic fever, basically means that the neutrophils, those infection-fighting cells, they are less than 500. And usually our goal is to keep them more than 500. When they are less than 500, when you get fever, big concern is, again, infection. And it's very hard to treat infection at that point. So we become very careful, monitor people closely, and sometimes may even need admission to the hospital, give intravenous antibiotics, and get the supportive care. But most of the times, neutropenic fever can be managed pretty easily, and people actually may not even get a lot of that, especially when the response to these drugs start coming. Respiratory tract infection, not very common usually with low blood counts, low neutropenia, but mild. Joint pain, muscle pains, a lot of people already have it, so it's kind of hard to see if that's because of the drug versus just a chronic thing. Dizziness, that becomes a little problem when you start the treatment, but again, goes away very fast. Headache, abdominal pain, they're not very common. Redness and itching at injection site, sometimes does not happen all the time. And chest pain, that's not very common, but you can just get random chest pain, sometimes concern for heart disease or other kind of lung infection, but that's again like everything else, if it's a lot of times mild and goes away. So long list, but I just want you to know that there can be side effects. Most of them a little on the milder side, and usually when I start treatment, people ask this a lot of times. And the other thing with azacitidine or decitabine is people's concern about hair loss, if they lose hair, and usually no, because they are considered more of less intensity treatment. So these HMAs that we called low intensity treatment do not have a lot of side effects, and they're very commonly used. We'll come to the intensive chemotherapy. These are not very common, and we don't use it all the time, but in some patients we do use it. And the treatment is very similar to what we do in AML. Lots of what we call intensive drugs with very high chances of side effects, but usually thought to be effective within days or within few weeks compared to the other drugs that we just talked about. So there are different regimens, kind of including cytarabine, daunorubicin, idarubicin, mitoxantrone, etoposide, fludarabine, cladribine, a new drug, CPX351. It's a liposomal daunorubicin combined with cytarabine. We also, brand name would be something like Vixius, pretty easy to pronounce. But these are lot of regimens that we combine these drugs and use it, and most of the times it's what we do with AML. But the concern again is toxicity, side effects with these drugs. And coming to the side effects, all the side effects that we talked with, the less intensity drugs are kind of become more and severe. So hair loss, heart failure, infertility, thyroid dysfunction, and other chances of cancer other than the MDS. So our big concern, obviously, are all these side effects, which we may not necessarily need in terms of MDS treatment. I just briefly wanted to mention these drugs, IDH inhibitors. IDH is a mutation that we see in MDS and AML. There's a new drug, IDH1 inhibitor, ivosidenib. It's a very new drug and being used single agent or in combination. IDH2, another drug, enasidenib, growing up very fast. And they're not typical chemotherapy. I won't go into more details, but just wanted to put it out there. You may hear about them pretty in near future. Venetoclax, the new drug, they can be in combination with azacitidine, decitabine, cytarabine, and others. And this is supposed to be kind of coming to the MDS part, but it is a new drug mostly used in AML. As I said, more in MDS, and it acts against BCL2 protein that regulates cell death. And and it works together with other drugs and it's pretty effective. I'll talk very briefly about bone marrow transplant, also called stem cell transplant, hematopoietic cell transplant. That's basically basically we use bone marrow tissue that's in the most bones that make stem cells. And the stem cells, that's where white blood cells, red blood cells, and platelets are made from. What we do is get those stem cells from the donor and give it to a person with MDS. So basically like a blood transfusion. So those stem cells go to bone marrow, grow and replace all the cancer cells, and all the healthy cells are made. And donors can be siblings, unrelated person, blood from umbilical cord, parents. So we have a lot of options for donor. And pretty much everybody has donor these days. It's an aggressive procedure, needs extensive workup, and patient must be medically fit, less comorbidities, willing to have long-term admission to hospital, multiple clinic visits. So it's very aggressive. You have to be in the hospital for almost a month at times and come to clinic a lot of times even after you're discharged. So it's a little hard for some people to do. And that's the only curative treatment in MDS, but saying that we need to be very careful to select the patients. So just giving some idea of how the data worked out with bone marrow transplant. In this study, almost half of people, the first study, almost half of people survived for 3 years compared to only 1/4. Again, similar thing with the other study, half people survived for 3 years versus 28 months. So pretty effective in high-risk disease if we can find the right patient population. Supportive care, Dr. Bhatt talked a lot about it, so I'll just skip that, but a lot of blood transfusion, infection treatment, those kind of things, and everybody should get supportive care. So choosing the best treatment, we should decide whether bone marrow transplant is possible or not. Is it being considered for a patient? So if yes, then we should start looking at the donor immediately And while we look at the donor, sometimes we can consider chemotherapy, sometimes we don't have to. If there is no donor, then we just start with hypomethylating agents, which are very commonly used. We talked about earlier, or all the treatment are just supportive care. So just to give you some idea of how we go with the treatment part, if the person is transplant candidate, then yes, then we look at the donor. While we wait for donors, let's say if it takes for like 3 or 4 months, and if there's a lot of disease in the bone marrow, then we kind of bridge that with chemotherapy. And when the donor is identified, we go directly to transplant. If donor is not there, then clinical trials, they are the best options. Hypomethylating agents, IDH1 or 2 inhibitors, they would be the therapy to go to. So that's for the transplant part. If there's no transplant candidate, if the person is not a transplant candidate, then we go to, again, treatment with clinical trials, methylating agents and IDH2 inhibitors, IDH1 or 2 inhibitors, and other treatment if there's anything else. So to conclude quickly, high-risk MDS needs early treatment. We cannot wait for a long time. Depends on patient preferences, medical fitness, disease characteristics. Bone marrow transplant has the best chance of cure, prolonging life. And we should start donor search as soon as possible if transplant is being considered. And low-intensity treatment with azacitidine, D-cytibine, cedazuridine are commonly used. And supportive care for all patients. Thank you.
Thank you very much, Dr. Dhakal, for sharing your time and expertise with us. We will now move into a Q&A session. Do we have any questions coming in from the audience? All right, we will start with our first question, and we'll take it from online. I will let you both decide who will take the question. The first question says, can you speak about any promising clinical trials for low-risk MDS?
Risk MDS, including luspatercept, is currently FDA approved after the other epoetin or darbepoetin is not approved, so that's been studied upfront. There are it's been combined with erythropoietin stimulating agent as well. There are other drug, one of which is called imelitistat. I'm mispronouncing it, but that is another drug that is been studied in low-risk MDS. Hypomethylating agent at a smaller dose, there is trial looking at that to see if that would improve outcome or not. So there are several treatment options that are being considered in clinical trial.
Thank you, Dr. Bhatt. Our next question is also coming from an online attendee who is asking, how often should a patient undergo a bone marrow biopsy? And what would be the circumstances to have more than one?
That's a fantastic question. You know, it depends upon several factors. If a patient has low-grade MDS and we are monitoring without treatment, one could utilize one of the two approaches, depending upon what the long-term goal is, patient's overall treatment plan, fitness, other comorbid conditions, and so on. So one option would be to monitor the blood count, and if the blood counts remain stable, then not necessarily do a repeat bone marrow biopsy. In some of my patients, following our discussion as to what approach we want to take, I have some patients where I don't repeat their bone marrow biopsy unless the blood counts goes down. Now, the second option would be to repeat bone marrow biopsy every so often, let's say every 6 to 12 months. The purpose there would be to try to detect progression of MDS sooner than what can be detected by decline in blood count. Now, the argument there is if you can detect MDS progression a little bit sooner, that may have treatment implication. The argument against doing a bone marrow biopsy is there is no guarantee that we would catch MDS progression if we repeat a bone marrow biopsy, let's say once a year. It's not that MDS is waiting for us to do a bone marrow biopsy before it progresses. It can progress before bone marrow biopsy or after the bone marrow biopsy. So I think those are the two treatment options depending upon what the patient and their treating physician decide. For higher risk MDS, if they are getting chemotherapy, then we do want to know whether treatment is working or not. So we would repeat bone marrow biopsy after treatment. With hypomethylating agent, we generally give treatment for 4 to 6 months before we say treatment is not working. So at the least, we would want to repeat a bone marrow biopsy after that. With transplant, we generally repeat a bone marrow biopsy a few months after transplant.
Thank you. Our next questions are related to high-risk MDS.
Okay.
The question reads, if a high-risk MDS patient evolves to AML, can the disease revert back to MDS with treatment? If not, why?
I'm sorry, I missed the question.
Say it one more time. If a high-risk MDS patient evolves to AML, can the disease revert back to MDS with treatment? If not, why?
So that's a great question. I think the reversion part is how we define the reversed MDS, right? So when we say AML from MDS, we're talking more about the blast count a lot of times, percentage of cancer cells in the bone marrow or blood. A lot of times, 20% is the cutoff. If we go from there, go from MDS to, let's say, even 21%, then you already have AML. In terms of doing the treatment and getting down to, let's say, 10%, then we would still consider it AML, even if the blast percentage is down. In terms of other mutation or cytogenetic abnormalities, at this time we're going more towards just the cancer cell percentage than those cytogenetics, but most of the times we still call it AML now that it's already on the worst side. But definitely it can get better and can come to the typical definition of MDS, but that's not what we usually use.
And I can add a little bit more to that. So if someone has AML after MDS, when we start treatment, we can see one of the few things. One is you go into remission, so you have no evidence of AML or MDS. And in many ways, that's what we want to see. In some situation, we may be able to get rid of the blast, but there may still be some dysplasia. So if a pathologist looks at that bone marrow biopsy, they may indicate that there are dysplastic changes reminiscent of MDS. So I'm not sure if that's what the question is about, but our ultimate goal is to really achieve remission completely and have no dysplasia at all. But in some situation, we do see persistent dysplasia.
Thank you. We also have another attendee who's asking about the use of MDS drugs outside the United States. I don't know if you're aware of any, but the question is asking whether luspatercept is being used as the first line of treatment outside of the United States yet, especially in the UK, is what they're asking for.
I don't exactly know the answer to that, but in general, I believe UK healthcare system, NHS, is a little bit more stringent, I would say. So it would be uncommon that the healthcare system would allow off-label use of drug outside of the approval. So my guess would be probably it would be difficult to get the drug outside of its approved indication.
Thank you. The next question is also about a drug, Nplate. Is Nplate FDA approved, or is it an off-the-counter medicine? When is it recommended for very low-risk MDS patients?
Yeah, so Nplate or romiplastim is a salt. It stimulates bone marrow to make mostly platelet count, but in aplastic anemia, drug like that are shown to increase overall all the blood counts as well. I'd briefly mentioned that this is a reasonable treatment option in patients who have mostly low platelet count, but rest of the blood counts are normal. It can improve platelet count. One of the concern is there is a small risk that it could stimulate the blast count, and blast count may also increase. That is a concern particularly in patients who have higher blast count. So if you look at clinical trial results or indication and off-label use, it does indicate that it could cause MDS progression. In patients where a cure is not possible or a transplant is not possible, let's say someone who is 70-year-old, have health problems, mainly have low platelet count, and we are trying to improve low platelet count to decrease the risk of bleeding. After discussion about a potential risk that this may possibly increase blast count, we have used medication like Nplate, so that's reasonable in that situation, but does have a small risk that MDS may get worse, especially if there is higher blast count. I don't think it's FDA approved, it's off-label use.
Thank you. Our next question from a patient says, I am a patient who was diagnosed with aplastic anemia and underwent transplant 7 years ago. I now have developed MDS. Am I at high risk for AML, and can I have another transplant?
Yeah, no, that's, I'm sorry to hear that. Transplant can be curative in aplastic anemia. Aplastic anemia, there is a lifetime risk of 10-15% risk of developing MDS. That's one of the reasons we recommend transplant in some patients who have matched sibling donor especially, or if the immunosuppressive treatment does not work. In general, with transplant, the risk of aplastic anemia transforming to MDS, we feel that the risk generally goes away. So that's the background information. In general, if there is a prior blood disorder or especially prior transplant, it does make it a little bit more difficult to do another transplant. But the longer you are out from the first transplant, your body may have recovered from the first transplant, so to say. So taking into consideration your health, overall well-being, fitness, what other health problems there are, a second transplant is certainly a possibility.
Thank you. My next question reads, what is meant by unclassified MDS? What would be the course of treatment suggested for unclassified MDS?
Yeah, that's a fantastic question. We did not go into various subtypes of MDS, but our pathologists look at different factors to say that this is, previously we used to call refractory anemia with excess blast, and then we started to call it MDS with excess blast. Now the most recent classification is MDS with increased blast. There are more recent classifications based on mutations. For example, if you have SF3B1 mutation or certain type of MDS with TP53 mutation, those go into specific classification categories. When you have an MDS that does not have these features that classify MDS into specific subtype, that gets put into a classification category called unclassifiable MDS. The treatment option or principle is still very similar. You would look at whether it's higher risk, lower risk, and then you would determine whether transplant is possible, whether chemotherapy is indicated, or supportive care is recommended. So overall, the treatment principles and treatment options are very similar.
Thank you, Dr. Bhatt. Our next question says, is it common for patients who start treatment to see a decrease in the blood counts? When should a patient be concerned about low counts?
Yes. So short answer is yes, actually. So the first question or first thing that we look at is why we're treating MDS. Is it more of low blood counts that we're treating there? Is it more of high cancer cells, or is it specifically for those genes and mutations that we talked about? Right, so somebody that starts treatment with intensive chemotherapy or azacitidine or decitabine, when they start, usually they do have low blood counts. That may actually add to what they had already, but as we move along, as the response to treatment, those treatment kind of gets better, then the low blood counts should get better as well. But while all those things happen, we give transfusion and support with all those blood counts and go from there. Yeah.
So I think it depends upon higher risk or low risk MDS. In higher risk MDS, lower count could be transient effects of chemotherapy that would improve over time, especially if there is response to treatment. In low risk MDS, if the counts are declining, one of the things that's important to make sure is it's not progression of MDS into a higher risk MDS.
Thank you both. My next question says, when should an MDS patient consult with a genetic counselor?
That's a fantastic question, and a little bit tricky one. It's an evolving field. Many centers still are not in a situation where we are ready to refer all our MDS patients to a genetic counselor. There have been discussions that maybe every single patient with blood cancer should be considered for genetic counseling. That's probably not possible at most of the centers. There are certain features that indicate there could be a germline predisposition. That means you are born with certain mutations that increases the risk of blood cancer. So there are few factors that indicate the possibility. So if I am seeing a patient with MDS, particularly a younger patient, let's say in their 50s or less, I want to know if they have had normal blood count at any point in their lifetime. If they always had low platelet count or other blood count, that raises a concern about whether they were born with a bone marrow failure syndrome. So all of those patients where they always had low blood counts should be referred. If in younger patients we do evaluate for certain mutations that indicate bone marrow failure syndrome. So if we find mutations that indicate, for example, Fanconi anemia or dyskeratosis congenita, those are the two most common conditions that can present with MDS without a prior history as an adult. So if we find those genetic changes, we'd want to refer those patients. If there are multiple family members with cancer, that's another indication for genetic counseling. When we do our standard mutation panel, we talked about a lot of mutations, but oftentimes we do a mutation panel. So if we see certain mutations, which could be a germline, so even when we do a mutation, not to diagnose a bone marrow failure type of syndrome, but to characterize MDS when we send mutation panel. If there are specific mutations detected, depending upon the what is called a variant allele frequency of the mutation, sort of how much mutation is there, so to say, our molecular pathologist can indicate where there is a chance that this could be a germline mutation. And then there are certain mutations which increases the chance that this could be something that a person is born with. So based on all of these factors, your treating physician may consider referring you to a genetic counselor.
Thank you, Dr. Bhatt. We also have a question coming in from a patient's spouse. It says, my spouse was recently prescribed luspatercept. When should we expect to see a response? And what are the common side effects that you have seen with patients?
Yeah, so these medications do take time before we see effect. We don't see effect in few days or even sometime in a few weeks. So you do have to wait for a few weeks to possibly a couple of months before we say that A, the treatment is not working, or B, the treatment dose needs to be increased. So that's the time frame we are looking at. In general, people, before I talk about side effect, they're just saying that any treatment you do on somebody else is well tolerated. When it comes to taking that same treatment, it's not well tolerated, but if you do it on somebody else, then it's easy. So oncologists often say these treatments are well tolerated, but that's in the context that we see serious side effects. So this injection in general is well tolerated. Generally, people can have fatigue, some flu-like symptoms is what are common. It's a sort, so there is a possibility that it can cause irritation of skin. Most of the time, otherwise people do okay. The serious risk, as I indicated, include a small chance that someone can develop blood clots and the blood pressure can go up. Those risks are not very common. They can happen whether the treatment works or not, whether the hemoglobin increases or not, but there is a slightly higher risk if hemoglobin goes up a lot. That's when there is a higher risk of blood clot and hypertension. That's why when the hemoglobin starts going up quite a bit, let's say more than 11 or so, we don't give that injection. So overall, with that approach, if there is not other risk factors for blood clot, the risk of blood clots are not high.
Thank you. Our next question says, how does a patient decide on a therapy? What is the difference between Vidaza and Dacogen? Why is one used over the other?
Yeah, that's a very good question. I can make some comment, but let's start with Dr. Dhakal.
So the question is how you choose between Vidaza and decitabine, right? So in regular clinical practice, we can basically use one another. When we talk to people about I guess the first question is what would the patient like? Because the characteristics with Vidaza or azacitidine with decitabine are slightly different. One in terms of how do you give it. Azacitidine can be given as a shot and intravenous. Decitabine is only intravenous. So some people would not like to do a shot, or some people would like to do a shot because it's pretty easy, you just get it and then you're done, versus intravenous where you don't, so you have to be there for half an hour, a couple of hours. So that's the part when the person wants to do a shot, then they may go for Vidasa in that part. The other thing with azacitidine versus decitabine is decitabine we usually use for 5 days. Azacitidine is more for 7 days. So again, same thing. You can start something on Monday and complete on Friday, and that's what you want. That's what you want. Then you could go for decitabine, because azacitidine is 7 days. So you'll have to kind of do it either every day for 7 days versus you get 2 days in between, like a weekend. So if you start on Monday to Friday, then you get 2 days off, and then you start again on Monday and Tuesday. So that's 7 versus 5 days. Other thing would be I briefly talked about the data from clinical trials that we saw. When I talk to people about those data, so in the phase 3 clinical trial that they did with azacitidine, people lived more than the supportive care, and there was really significant results there. So azacitidine people, half of the people lived around 2 years, 24 months versus 15 months with other group, right? So with decitabine, again, officially we don't have that phase 3 trial result, because it was around 10 months versus 8 months in that clinical trial, which was not significant. So there are few things that people look at, but again, when we describe those things, they're pretty similar, and either one should be a perfectly reasonable option there. And just to add, with the new drug with decitabine cedazuridine, it's a pill, right? So for the pill, you just stay home, take it. You don't necessarily have to come to the clinic for someone to give it to you or get the treatment from. So you kind of are limiting the clinic visits, and that's really something. I mean, that's great that some people want to do regardless of other drugs.
Thank you.
Wanted to add something? Okay.
For a patient who was diagnosed with intermediate risk, MDS intermediate risk, through the IPSSR, would Procrit be a viable course of treatment?
Yes. So I think there are different ways that we look at in the intermediate risk part. I won't go into the exact numbers, how we do it, but usually even in the intermediate part, it depends on what the main concern is. Let's say the mutation and chromosomal abnormalities is not that bad, but the big thing that we're treating is more in terms of anemia or thrombocytopenia, low platelet counts, then you could just do the treatment for those blood counts. But if there's another concern with high cancer percentage, or if there are other mutations that we're worried that they may go down the line becoming AML, then we'd rather go for other treatment, like we talked about the high-risk disease, like decitabine, azacitidine, or other intensive chemotherapy, or even go for transplant, then we'd lean more towards that.
Yeah, I can add a couple of comments. So, when classification changes, sometimes it becomes tricky, but since now we have molecular IPSS classification, you could consider talking to your oncologist about whether it is possible to do mutation testing that can further differentiate whether you'd be on a slightly higher risk category or slightly low risk category. So that would be one thing to consider. Otherwise, intermediate risk MDS by revised IPSS is a little bit tricky thing. As Dr. Dhakal said, even within the revised IPSS intermediate risk category, we think about whether it's a little bit on a higher risk of intermediate risk MDS or a lower risk side. And then what exactly is going on, your overall health, fitness, and so on. In someone with revised IPSS MDS, it is considered reasonable to even consider transplant. But if you are doing well, then it's very reasonable to just do medicine like Procrit. So revised IPSS intermediate risk MDS is a little bit tricky thing, and those are some of the considerations.
Thank you. I think this will be my last question today. When should combination therapies be used to treat MDS? Are combination therapies every first line in therapies?
Combination treatment for MDS.
Yeah. So I think we're talking about more of, I don't know if it's more of high risk or low risk. Let me answer more about the high risk part. So when we are talking about the high risk disease, again, the standard of care, at least at this time, is just one drug. So just like just like the low intensive chemotherapy drugs. So again, azacitidine, decitabine, and the pill. That's more in the less intensive side. In the higher or in the intensive chemotherapy part, we always use combination. So that's more of the AML part. But coming back to those HMAs, these days in clinical trials specifically, we're trying to use combination. And so combination can be with different kind of drugs. The most common or very exciting combination these days is with venetoclax. Venetoclax is a pill, very common and very effective drug that we found in AML. We have a lot of data in AML from the venetoclax and the HMA drugs. And that's definitely one thing that we could think about more if we're trying to, let's say, somebody that we're trying to get the cancer cells very low or trying to go for transplant, where we're trying to get the response faster. That's what we're considering. With all the new drugs, like IDH, ivosidenib, enasidenib, the new anti-mutational drugs that I talked about, they're also trying to combine them with these HMAs. So lots of combinations going on, even if it's not the typical standard of care right now, but they will definitely be standard of care down the line. And they're already in the clinical trials with pretty good response.
So I can add a little bit more to that. You know, the many drugs are initially studied in AML or acute leukemia, and then they start to get studied in myelodysplastic syndrome. So some of these drugs like venetoclax and IDH inhibitors have been studied in AML, and venetoclax and ivosidenib in the upfront setting have shown improved results in AML compared to just a single drug. So in AML, those combinations are considered standard of care. High quality trials are not available yet in MDS, but higher risk MDS oftentimes is considered very similar to acute leukemia. So what works in AML is likely going to work in MDS. For that reason, venetoclax is often combined with drugs like azacitidine in higher risk MDS. There are initial studies that have shown that the chances of remission is higher when you do combination. And this is where it gets a little bit tricky, but just because the remission chances are higher, does that really mean that you're going to live longer or not is not clear. There are other studies where the chances of remission have been higher, but because of complications or things of that nature, people did not necessarily live longer. So one could make an argument that in MDS, the combinations, we don't have as much data to say that combinations should be the standard, but some people make can make an argument that those data are available in acute leukemia, and there is also data that the chances of remission is higher. If somebody achieves remission, even if, let's say in the worst case scenario, people don't live longer, improvement in blood count often means that their quality of life is better and so on. So if you can safely use the drug in combination and likely are going to improve outcome, maybe combination should be considered. So for that reason, it's a common practice that venetoclax is often combined with azacitidine type of drug in MDS, but from a trial perspective, from a pure science perspective, we don't have high quality trial specifically in MDS.
Thank you. I think those were all our questions for today. Thank you once again, Dr. Bhatt and Dr. Dhakal, for spending time with us today. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on the replay or navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us in one of three ways. You can send an email to help@aamds.org, or you can call the AAMDS helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan for future educational programming. Also, be sure to visit the exhibit hall and chat with the conference sponsors. The next educational sessions will start in approximately 13 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure and diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the last 40 years. This concludes the session.